Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. We routinely see patients with dementia in our sleep clinics, but we often don't meet them until they present with a sleep complaint, such as insomnia or obstructive sleep apnea. We know that sleep and dementia have a bidirectional relationship. Is there a way to identify those who are at higher risk of dementia and intervene earlier? Is there a polysomnographic fingerprint? Should polysomnography be performed in those who are felt to be at a higher risk of dementia? How can we, as sleep clinicians, potentially impact the course of cognitive decline? Are there special considerations for our patients with dementia and a comorbid sleep disorder? Dr. Brendan Lucey is here today to help us explore this further. Dr. Lucey is a professor of neurology and sleep medicine. He is a section head at Washington University, and his current research interests are in sleep, aging, and Alzheimer's disease. Thanks for joining us today.
Thanks for having me, Dr. Khosla.
So let's talk about the bidirectional relationship between sleep and dementia. How does dementia change our sleep?
That's a great question. We've known for a long time that individuals with dementia have problems with their sleep. There's a lot of different problems that can occur in individuals with dementia, including they're waking up confused, changes in the timing of their sleep, they're awake during the night or having insomnia, and they can have problems getting back to sleep. And this not only can affect the patients, but also the caregivers. And there's been an enormous interest recently in really looking at the caregivers and how their sleep is being impacted by individuals with dementia as kind of a downstream or secondary effect of how the sleep is changing in the individual with dementia. And these challenges can impact whether or not that patient with dementia is able to stay in the home with that caregiver, or whether or not they end up having to move to an assisted living facility.
So how does Alzheimer's change the timing of sleep?
The changes in the brain that we see with Alzheimer's disease can affect the internal clock, the body's circadian rhythms. Studies have shown that even in very early Alzheimer's disease, you start to get circadian dysfunction, such as reduced amplitude of the endogenous circadian rhythms. So these are the changes that are occurring inside the body, like the oscillation of cortisol levels. But it's also been shown that you can get disruption of the rest activity rhythms that are measured over days with an actigraph wristwatch. That the amount of rest activity rhythms is flattening instead of having robust activity during the day and then quieter periods at night.
So is that something that maybe we would see somebody in clinic that had this sort of irregular sleep-wake cycle? Should that make us think about dementia, or is it something that's sort of a later, that indicates that they've already been diagnosed with dementia, right? It's sort of a later finding.
I think that's a really interesting question, and I think there's multiple ways to look at it. I think if you're seeing an older adult in your clinic who has a sleep concern, but they don't have a cognitive complaint, so there's no problems with memory or thinking that they're worried about. I think for that individual, treating their sleep disturbance, making sure they're getting restful, restorative sleep is probably at this point, the best thing that the evidence says you can do. There haven't been studies that show that if you intervene, at that stage, that you're going to change the trajectory of what might happen. Even if someone is already starting to show memory problems, we need studies that show that if you say treat someone's sleep apnea and an individual has mild cognitive impairment, that it's going to result in not just improvement in their memory and thinking, but changing in the trajectory of their progression of whatever the dementing process is, if it's Alzheimer's disease, for instance. And then there are individuals who are further down the progression of Alzheimer's disease. They're more severely affected, and there probably a sleep intervention is probably not going to change the trajectory of their disease, and it's focused more on symptom management. As I mentioned earlier, helping to keep them in their home environment where any sleep disturbances aren't affecting their caregivers to the same degree. Depending on where someone lies on the spectrum of Alzheimer's disease, from sort of preclinical, asymptomatic, they don't have any problems with memory and thinking, versus moderate to severe Alzheimer's disease, your goals would be different in those situations.
But do you know what this kind of makes me feel, though, is I kind of wonder if, should we be doing polysomnography in like first degree relatives of somebody with Alzheimer's, right? Like, is there something, so we know later, right, a sleep intervention doesn't change things, but what if we identified them earlier? Like, is that maybe something we should consider when we are, doing imaging and spinal fluid testing and all of that stuff?
There's a lot of interest in using sleep as a marker for the changes with Alzheimer's disease, and I think that's what you're getting at with this question. And the evidence isn't there yet to say that yes, that's something we should be doing routinely, but it's something that I'm very excited about in my research, because we have really good markers for the pathology changes in the brain. So the accumulation of amyloid beta or the accumulation of tau protein in the brain, either with imaging, so we can visualize that with PET scans. We can measure the levels in cerebrospinal fluid, and increasingly we can do blood tests for amyloid pathology. And now there's new evidence that we may be able to do that for tau as well.
Oh wow!
And so we can determine these pathological stages of the changes in the brain. I think with great precision and decreasing invasiveness. But what we're missing is a marker of the brain's function. Now we bring individuals into the clinic. We do cognitive testing, where the participants will answer questionnaires that target either sort of general cognitive function or specific domains. These are often done, in a research study at certain periods of time, say once a year. They could be done in the morning at one visit, in the afternoon at the other. They're potentially time of day effects. It's very costly, because you generally need a person to administer these tests.
Oh, sure.
Although increasingly they're looking to do them on the computer or on phones. But sleep is something that could be non-invasively monitored over multiple nights and give you a measure of how the brain is functioning that could go beyond the pathologic changes with amyloid and tau. And that's my hope, that we get there at some point where we can use sleep as that non-invasive marker of brain function to track both Alzheimer's disease risk and potentially even response to treatments.
So what do you think the most important sleep-related risk factor is for Alzheimer's? I mean, is this sleep apnea?
I think that sleep apnea is a strong candidate for a sleep disorder that we could intervene on and potentially change someone's future risk of developing cognitive impairment for a couple of reasons. One, there's a lot of evidence associating untreated obstructive sleep apnea with increased risk of future cognitive impairment. It also has been associated with the pathologic changes in the brain. And there's some evidence that if you treat sleep apnea, you can actually affect the levels of these biomarkers over short periods of time. And so it's a sleep disorder for which we have a lot of different effective interventions. I think that where the evidence is lacking is that we're going to treat the sleep apnea, specifically to, prevent Alzheimer's disease in the same way that I don't feel like we're there yet for we're going to treat your sleep apnea and prevent you from having a stroke, a second stroke. There's studies that are ongoing to show that. But I think in terms of improving sleep, reducing those respiratory events and all the physiologic stresses that go along with them, I think that sleep apnea is certainly one sleep disorder that has a lot of evidence to support treating and hopefully having a positive impact on AD risk.
So, what about insufficient sleep? Is that a risk factor?
Insufficient sleep has been associated with future risk of cognitive impairment or problems with memory and thinking. Interestingly, long sleep has as well. So there's studies that have shown that both short and long sleep duration is associated with worse cognitive performance over time. And what I think is, my hypothesis is that's going on there is that the short sleep may be a sign of insufficient sleep, that they're not getting enough time, whereas the long sleep, potentially there's something that's disrupting the sleep that's making it less restorative, and so they may be doing a lot of time, but they're not doing good time. And many of the studies that have shown both the long and short sleep duration is associated with future risk of cognitive impairment, they've generally, had periods of time of follow-up of, 5 to 10 years. In studies where they've had much longer follow-up, like 20, 25 years, the short sleep does seem to be the greatest risk factor of having future cognitive impairment.
Oh, wow. Okay.
What may be going on is that when these individuals are younger, like say in their 50s, the short sleep is potentially a risk factor for developing cognitive impairment, but long sleeping is not. So I think it does depend on sort of where someone is in their lifespan, and also the relation of like when they've looked at the sleep duration versus how long they've followed up their cognitive function.
I love that you consider 50 young. I just turned 50 this year.
Absolutely.
What are some of the polysomnographic changes that we see in Alzheimer's? And where I'm going with this is, how do you know if it's maybe like an age-related change that you see in sleep architecture versus pathology?
So we're definitely not at the point where we do a sleep study and we see, a certain sleep time or sleep efficiency or even percentage of slow wave sleep or slow wave activity that we can say that this person, should be investigated for Alzheimer's disease, or that we could pick them out. I think there's a lot more research that's needed before we're going to be able to, determine sort of someone have this disease like Alzheimer's disease versus controls based on a sleep study. That being said, there are changes that are seen, like decreased total sleep time and sleep efficiency, less slow wave sleep, less REM. And these are Alzheimer's disease patients, compared to healthy older adults, which I think is an important comparison around your question. We really need to look at Alzheimer's disease patients compared to age-matched controls who don't have Alzheimer's disease in order to really pick out, are these just changes with aging. AD patients can also have longer sleep latency and wakefulness after sleep, as well as more arousals, as we talked about.
Well, because I think we've all seen those studies where you look at the when you're reading your raw data, right? And you see really, really fragmented sleep, and you sort of see like a shorter amplitude of delta, right? Or you just see lots of transitions from sleep to wake. And, sometimes you just pull up the hypnogram and I'm like, holy buckets. And right. And I kind of wonder, I'm like, boy, no wonder they're sleepy. And then now I guess what I'm thinking of is, should I also be thinking that they, may be at risk of dementia, or is dementia an underlying cause of this sleep fragmentation and these changes that we're seeing?
Absolutely. Fragmented sleep, including, measures like increased daytime napping, which you could, we could argue is fragmented sleep by moving some of it to their daytime period, indicating that the sleep is not restorative overnight. Those are all potential hallmarks of individuals with Alzheimer's disease. I think where we need a lot more research to figure out how to apply this information is in looking at individuals really early in the Alzheimer's disease process, or even potentially before they begin to develop the changes in the brain with Alzheimer's disease. So the Alzheimer's disease has a very long, we call preclinical or asymptomatic period where amyloid plaque is forming. So in this asymptomatic period, which can run 15 to 20 years, individuals don't have problems with memory and thinking. And but they have been shown to have some changes in sleep. There was a study that was conducted here about 10 years ago by my colleague, Dr. Yoel Ju, using actigraphy to measure sleep. And what she was able to show is in cognitively unimpaired individuals, so no problems with memory and thinking, those who had amyloid accumulation in their brain or were quote unquote amyloid positive, they had lower sleep efficiency, about 3%, than those who were cognitively unimpaired but had no amyloid in the brain. So they didn't have this preclinical phase of Alzheimer's disease. So we're starting, and this has been shown with a number of different sleep measures, like non-REM slow wave activity, which is a measure of sleep homeostasis, sleep latency, and even sleep duration. And so you have some of these changes that are occurring very, very early in the process. And the question is, do we have enough evidence yet to say that if someone comes in, they're cognitively healthy with no memory or thinking problems, does this specific sleep parameter or say fragmentation pattern on a hypnogram indicate that there's someone that we should be screening for Alzheimer's disease? And I think that we're definitely not there, in my opinion, based on the evidence. And where I think we're more likely to go is that with these blood tests that are being developed, older adults will be screened for, are they amyloid positive?
Oh, sure.
And then if they're amyloid positive, we monitor their sleep going forward. And in the context of someone who's cognitively unimpaired, amyloid positive, do we start to see changes in sleep over time that predict if someone's going to develop cognitive impairment, and then, start an intervention really early?
Well, that's kind of what I was wondering, right? Is there a way, and I didn't realize the runway was so long, 15 to 20 years. I didn't realize that's a pretty long preclinical phase, right?
It's very long.
Yeah. So then I'm kind of wondering to this idea, I get that we're not there yet with the data, right? But when you look at that, lower amplitude of delta sleep, and you think about the, sort of cleaning of, the debris in the brain, to me, it kind of makes sense that if you're not having as much of that, it's going to build up more,
Right.
and maybe that's going to affect, right?
Right.
So you mentioned sleep fragmentation. Is that how sleep apnea impacts our risk for dementia, or is it hypoxic burden? What about cognitive arousals? Like, what part do you think it is?
If I had to pick something, I'd pick all of the above.
Okay.
Obstructive sleep apnea causes so many different disturbances to the human body, from the frequent arousals that you mentioned disrupting your sleep. You also have increases in blood pressure, changes in cardiac function with each of the with the repetitive respiratory events, and it can impact inflammation and metabolic dysfunction, and all of those have been implicated in Alzheimer's disease risk. So if you just think about sort of big buckets of problems, you got cardiovascular, vascular disease, and metabolic dysfunction, and the immune system, as well as the sleep effects. Sleep apnea is kind of hitting a lot of those risk buttons, right? And so that's why I think that potentially all of them could be playing a role.
Well, and I feel like we are, as a field, paying more attention to these cognitive arousals, right? With the, new 3% or arousal hypopnea rule, new-ish hypopnea rule. And, just this idea of understanding that it's not all about the desaturation, right? It's about,
Right.
you've got something happening to the airway and there's some consequence, right? Your brain's waking up or you're desaturating or whatever that is. But that, when you have that really fragmented sleep for whatever reason, that they've, you look at it and you're like, they've got to be sleepy. Like this cannot be their ever. And I'm hoping it's just first night effect, right, in the lab or something. But yeah. And so, it's funny because you've said that there's no data yet. Is this an active area? If we're talking about, does treating obstructive sleep apnea impact the onset of Alzheimer's? Is that a current area?
There are several trials, none of which I'm involved in, that I'm aware of, that are looking to treat obstructive sleep apnea and see how it affects, both cognitive function and the Alzheimer's disease pathology, or at least the markers of the pathology. And so I think those studies, and these are larger trials. There's been some smaller ones that have shown, for instance, that the more you lower the AHI, the greater you're going to reduce the soluble levels of amyloid beta and tau in the fluid around the brain. But these would be. There was a study where there was a study led again by my colleague here, Dr. Yoel Ju, who diagnosed patients with obstructive sleep apnea and then performed a lumbar puncture the next morning. And then they were treated with CPAP for 30 days and had another sleep study and then another lumbar puncture. And it showed that the more the AHI was lowered, the more the soluble levels in the fluid around the brain of amyloid and tau were decreased.
Huh.
So that's over a relatively short time, and it was a fair, it's an invasive study. It requires a lot of those participants, given that it's 2 lumbar punctures in a relatively short period of time. And ideally, you'd want to show that you can really reduce it over longer periods.
So that reduction means that it's producing less tau?
The levels of amyloid beta and tau in the cerebrospinal fluid around the brain is influenced by production or release and the clearance. And both of those processes can be affected by sleep. So amyloid beta and tau are released with neuronal activity. So when you're awake, there's generally more neuronal activity. You're going to be releasing more of these proteins, but there's also an effect of sleep on clearance, where clearance is being increased. And we did a study of very small. It was only 5 individuals, but they came back and did 2 different intervention arms. And so the first group would be control group. They came in the morning and we placed lumbar catheters in their lower back and sampled the fluid around the brain, cerebrospinal fluid, every 2 hours for 36 hours. And so they were awake during the day. We allowed them to sleep at night. And then they were up the next day. So that was their 36-hour period, basically one sleep time. And then they came back and they did a sleep deprivation group where the catheter was placed to collect the cerebrospinal fluid every 2 hours, but they stayed up overnight. And this was a behavioral intervention where they stayed up, they were reading books, talking to the nurses, but no stimulants were involved. Okay. And we showed that if you do that, these proteins increase about 30 to 50% overnight in the fluid around the brain. But interestingly, with the sleep deprived group, they actually fell in the blood, suggesting that the clearance from the CSF to the blood was being impacted by the sleep loss in some way, and that was also raising the concentration. So we think that both sleep loss increases the production and release, and also prevents the clearance.
That makes sense. Yeah, that makes sense. So let's take a short break, and when we come back, we'll talk more about the relationship between sleep and Alzheimer's disease. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
Join colleagues and subject matter experts February 23rd through 24th for Sleep Medicine Trends 2024. Explore emerging technologies and innovations in sleep medicine that will enhance patient quality of care. Learn more at aasm.org/events.
Welcome back to Talking Sleep. We're talking with Dr. Brendan Lucey about sleep, aging, and Alzheimer's disease. When we talk about trying to improve the sleep, we've kind of hit on sleep apnea and we've hit on insufficient sleep, but what about insomnia?
Insomnia has also been associated with future cognitive impairment and Alzheimer's disease risk. A study from Ricardo Osorio at NYU in 2011 had found that individuals who were cognitively unimpaired, complained of insomnia, had a greater risk of progressing to Alzheimer's disease. And so it certainly has been associated with increased risk of developing AD. And I think a lot of the work has gone into figuring out what's the mechanism. And we've talked about some of that already. Is it that when individuals are experiencing insomnia, they're awake when they should be asleep. And so that's increasing the production and release of proteins like amyloid beta and tau, as well as impairing their clearance.
We were talking with Chris Deppner a while ago about those studies with insufficient sleep and cardiometabolic disease, and how maybe part of it is also related to circadian rhythm mismatch, right? Because when you try to induce insufficient sleep conditions, you're letting them stay up late, right? And you're shifting their circadian rhythm. And so that was kind of an interesting thing that came out of that maybe it's not just insufficient sleep in isolation, but maybe there's a component of circadian rhythm too.
Yes, absolutely. I think it potentially could. I think that there's evidence, as we've already talked about, that circadian dysfunction has been associated with increased Alzheimer's disease risk. I think acutely, at least, we did not find that the changes in our studies with sleep loss, and we were measuring changes over hours of amyloid beta and tau in cerebrospinal fluid and blood. That from the evidence we had was suggested that we weren't shifting their circadian rhythms over that short period of time. So we had measured cortisol in both cerebrospinal fluid and in the blood, and we didn't see any shifting of their circadian phase. And I think it'd be a little surprising to see something like that over just one night potentially. Yep. But what I do think could be a contributor is if someone's awake when they should be asleep, right? Then their sleep behavior is going against what their internal clock is telling them that they should be doing, and there's going to be a metabolic and a physiologic cost to that, and I definitely think that could contribute to their AD risk and increase it, and certainly disorders like shift work disorder, I think results in significant sleep fragmentation and potentially long-term risk for Alzheimer's disease and as well as numerous other disorders associated with sleep loss.
So, we talk a lot about insomnia and treating insomnia with CBTI. Is it effective in this population with maybe some cognitive decline?
Cognitive behavioral therapy for insomnia is very challenging in patients who have Alzheimer's disease. That being said, it's obviously the first line treatment that we would want to try and avoid the use of medications just because of the concerns about the side effects that they may experience from sedative hypnotics, and some of the things that people could try that even in an cognitively impaired individual may be helpful would include planning ahead that they have quiet nighttime activities before bed, sort of a settling down period. If patients are individuals with Alzheimer's are getting up during the night, having alerts that are triggered by wandering, like bells on doors, discouraging, long, lengthy daytime naps and getting bright light during the day. More involved interventions, like progressive muscle relaxation therapy, for instance, would almost certainly be much more of a challenge in an individual with symptomatic Alzheimer's disease.
So if CBTI isn't always as effective, are there maybe some hypnotics that we could consider in this population?
Yeah, I think that if behavioral interventions have failed and it's at the point where something needs to be done, either for the caregiver's sleep or if they're in an assisted living facility, whatever that specific circumstance is, sometimes hypnotic medication is required. One that I have recommended if it comes to that point is suvorexant, because suvorexant has been studied in treating insomnia in individuals with mild to moderate Alzheimer's disease, and has an FDA add-on indication for that. And so, based on that study and that data, that is usually the hypnotic medication that I've recommended for patients. And I think the mechanism compared to a drug like zolpidem is more favorable, because in an instance of zolpidem and other sedating medications, they're inducing sleep via sedation, whereas the dual orexin receptor antagonists like suvorexant, and there are others that have been approved since then, they're blocking orexin, which is a wake-promoting neuropeptide. And so that mechanism may be the reason why it was able to be approved with, fewer side effects than are seen with others.
Yeah, and I think that kind of fits clinically. I'm just trying to think back to our patients. And so I've been kind of pleasantly surprised by that, because it is sort of touchy, right? When you have somebody with, cognitive impairment, that you don't necessarily want to add anything that is, potentially going to make it worse, right? So I think it's always a conversation, right? And I feel like even though we know that the behavior is such a huge part of it, I feel like that burden falls really on the caregiver, right? To kind of say, nope, you got to stay up now. And it just feels sort of like this unfair burden that, and then I think there's a little bit of blame too. Like, the caregiver's like, I know I shouldn't let him nap in the afternoon, but I really have to go get groceries. Right.
Right.
And so I'm wondering, how can we better support like the caregiver while still keeping, the patient at home? And I don't know if there's an answer to that. No, I mean, honestly, because it's hard.
Yeah. I think the caregivers have an enormous burden in patients with dementia. And some of the circumstances you described about, let them sleep so that I can go do, this task like grocery shopping or whatever it might be. I think that is something that's completely natural, and caregivers should definitely not feel bad about that. And I think that the burden in that we have to be careful about is, we're asking them to implement this sleep therapy in addition to a lot of other things that I'm sure that they're having to do to take care of that individual, as well as just maintain their own lives. And it can create, a potential for, some adversarial aspect to it if they're really trying to, say keep them up during the day, discouraging lengthy daytime naps, or if they're waking up at night. And I think that caregivers just need to, be told or given permission, or however you want to describe it, to that they just have to have a non-confrontational tone and just do their best to try to get them to implement that behavioral change. And that, it's not going to be perfect, and that's okay.
And I think that's such an important message. I'm thinking back to some patients, and you see them over years, and you can see the cognitive decline, and you can see the sort of change in personality, right? And I think sometimes it is exactly like you're saying. This is ideal. We would love for you to be able to do this, but we totally get that, it's not always feasible, and it's okay. Right? In medicine, perfection is the enemy of good. It is okay.
That's right.
If you need a break, you need to take care of you too, right? And I feel like part of that, and I think it is like an important way to partner with that caregiver too, right? And maybe that's how we at least start with that support, because I don't think we are built to have a lot of respite care and a lot of home health and things like that. Just sort of for patients with dementia.
Absolutely. I mean, you asked what we can do for them, and I think that there's certain support that the caregivers need that they sort of go beyond what we're really able to provide as physicians. It's more of almost a societal level of change that's required. Mm-hmm. And I think a recognition with the caregivers that cognitive behavioral therapy for insomnia is challenging for anyone. It requires, generally pretty intense, upfront visits, and, the patients, need to either come back frequently or have frequent interaction with with who's ever implementing it. That certainly has been our observation. If the follow-up's 3 months later, you see them back and it's like, oh yeah, I stopped doing that a week after the visit or something, right?
Yeah.
And so I think that there can be challenges in CBTI and in any population, and they're just magnified in those with dementia.
Yeah, for sure, right? Because you need to be engaged, and you need to be willing to make the changes, and you need to really kind of invest that time and effort into, changing these behaviors. And it's hard.
Absolutely.
It's hard to do long term. So yeah, I think it's, it's a conversation that we need to keep having, though, I think, because we don't have answers now, right, to support the caregivers, but maybe we need to be thinking about that a little bit more, and coming up with something a little bit more user-friendly for, like a modified CBTI, for example, caregiver CBTI, have the lighting that automatically goes, up and down and whatnot, and, to emulate, right? Like just, I don't know.
There's groups that are studying, how to implement those behavioral interventions in this population. And I think that those will be exciting things to see, what they're able to find, because this is an area where relatively low cost, certainly low risk for intervention could have profound effects, especially if it's able to keep that patient, in the home with that caregiver. I think that's an outcome that everyone would agree is the best one.
And I think,
if
it can work. And I think sometimes they're, so tired that they don't maybe, they're sort of in survival mode rather than sort of taking a step back and looking at it broadly, and
absolutely.
And I think, sometimes I'll tell people when we're talking about this and how important the lighting is, because sometimes that's sort of this is woo woo, this is not real, right? And I'm like, no, it's real. Like the lighting is important. And I'll tell them that, the space station has lighting to emulate, sunrise, sunset, and it has all of that stuff, right? Because they need to make sure that they, help the astronauts sort of have a circadian rhythm. And so when they kind of hear that, they're like, oh, okay, this is not like, you're not trying to sell me a light. This is actually important. And so, yeah, I think it's we have to be willing to think about creative solutions, I think.
Yeah, and that quiet time, before going to bed becomes a cue that helps to promote, I think, better sleep quality and sort of in a routine. which is also sounds simple and can be hard to implement depending on what's going on with the caregiver, right?
Yeah.
And their lives, but could be immensely beneficial.
Well, it's true, especially when they're both asleep on the couch, right?
Right. Right.
So any final thoughts?
No, I'm just so thankful to you for, highlighting this important subject around sleep and Alzheimer's disease. I think it's an area that has tremendous potential to improve the quality of life of patients at risk for Alzheimer's disease or who have it, but also there's some potential to to use sleep to monitor for Alzheimer's disease risk and even potentially prevent or delay the onset of symptoms. So it's a very exciting time in this area of research.
I really am hoping that we get to a point where you can identify something in the EEG that's maybe predictive, right? And then you can intervene
Absolutely.
early. That's what I'm hoping. So I'm counting on you to figure it out.
There's a lot of people working on that.
Well, thanks for joining us today and helping us better understand the relationship between Alzheimer's and sleep.
Thank you for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.